Okay, welcome to the June 19th Treatment of Substance Use Disorders and Addiction during COVID-19. I'm Tim Wiegand, and we'll be moderating this webinar brought to you by the American College of Medical Toxicology and the American Society of Addiction Medicine. Joining me as moderator is Dr. Gloria Bashevitz, Medical Director of Strong Recovery and Professor of Clinical Psychiatry and Department of Psychiatry at the University of Rochester Medical Center. I'm very pleased to present a very distinguished group of panelists. We have Alexandra Omaduchi, a fellow in the Medical Toxicology Fellowship Program at the Lehigh Valley Hospital, Muhlenberg in Bethlehem, Pennsylvania. She's also joining with Dr. Matthew Cook, Chief of the Division of Medical Toxicology, Department of Emergency Medicine at Lehigh Valley Health Network, Allentown, Pennsylvania. Dr. Brian Hurley is the Director of Addiction Medicine, Los Angeles County Department of Health Services. Dr. Ryan Magnuson is Assistant Professor, Department of Medicine, Pulmonary Disease and Critical Care at the University of Rochester Medical Center. Dr. Kelly Ramsey is the President-elect of the New York Society of Addiction Medicine. And Dr. Henry Swoboda is the Assistant Professor, Department of Emergency Medicine, Rush University Medical College, Chicago, Illinois. He is also a medical toxicologist and runs the Toxicology and Addiction Consult Service. CE credit is available both by AMA and ACCME. Please complete the surveys at the end of the webinar and through the ASAM web portal. None of the panelists or moderators have any conflicts of interest to disclose, and I'm going to jump right into the first case. Case one involves a 47-year-old male who's been furloughed during COVID-19. He's been drinking heavier since his furlough after trying to self-detox, presents to the emergency department related with tachycardia, hypertension, tremors, and hallucinations. He'd been working on a contracting crew that downsized, and he's been home for about 4 weeks. Prior to his furlough, he drank heavily, primarily whiskey, when getting home from work. It was maybe half of a bottle each night, but I started drinking in the morning before I knew what I was drinking all day and had to drink at night because I was waking up drenched in sweat and in a panic. The patient has family in the area but hasn't seen them during COVID. There's been occasional phone calls. He has a primary care physician who he sees intermittently who prescribed a brief course of lorazepam for anxiety about 2 weeks into his escalated drinking. The patient reports he told his primary physician that he had anxiety and insomnia related to the furlough and COVID, but he started taking the prescription, which was lorazepam, 0.5 milligrams, 3 times a day, 30 tabs, and realized it helped stop the shakes, but he was still drinking anyway. And when he ran out, it was terrible, and he tried to stop. Not taking other meds, but has been on antihypertensives in the past, not currently. Smokes half a pack a day, no other substance use. No previous treatment attempts, no history of detox. He's drinking increasingly heavily at night for 6 months prior, separated from his wife about 6 to 7 months ago, and then about 4 weeks of 1.5 to 2 bottles of 45 to 50% alcohol whiskey daily, starting in the morning with the furlough, and then the 30 times 0.5 milligram tabs lorazepam over about 5 days. It was a 10-day prescription, but he overtook them. So lorazepam ended about 5 days prior to the patient presenting. The patient has about 2 bottles of whiskey per day for 3 days after the preceding history, then didn't purchase any anymore because he wanted to stop. He's tired of this. Called one of his sons and told him he was stopping his drinking. And 2 days later, when his son called and he didn't answer, he drove over to his father's house. He finds him sick, shaking, not looking good at all. The son brings him to the ED, and the patient traverses the intake process, going through the screening for COVID, the risk, the symptoms through a tent in the front of the ED. His initial vitals include a heart rate of 120 beats per minute, a blood pressure of 160 over 95, respiratory rate of 20 breaths per minute, and his temperature is 99. He's tremulous. He hasn't slept in about 48 hours. He's able to provide some history, but intermittently confused and tangential. Mistakes dates, and he's not able to describe how he had arrived at the ED. His labs are with negative ethanol concentration. He has a hypokalemia, a little bit of an anion gap with a bicarb of 17. And his AST is 210 and his ALT is 145. An ethyl glucuronide subsequently returns positive, but his urine screen is negative for amphetamines, methamphetamine, cocaine, THC, opiates, It's positive for benzodiazepines, confirmation pending. My question to the panelists and to Dr. Amaguchi to start, what is your perspective on alcohol use and the increase in complications related to excessive drinking during the COVID-19 pandemic?
Thanks for having me, Dr. Wigand. So this case is unfortunately something that we've seen quite often over the past 3 months. We pretty early on when the COVID pandemic started and they closed the liquor stores in our state, we started seeing an increase in patients with alcohol withdrawal. And over the past 3 months, we probably actually increased our alcohol withdrawal volume by about 100% at our facility. So we are certainly seeing a lot more alcohol withdrawal, and it seems, and this is just anecdotally, that it's been a little bit more severe than what we're typically used to.
And Dr. Cook, keep going. I was going to ask if you can continue. Essentially, the questions are all related. I mean, has it impacted your ED, hospital, or clinic practice? And then, how would you approach a patient like this is escalating heavy alcohol use along with the sedatives, with delirium, autonomic hyperactivity, and other sequelae now 48 hours. So maybe you can continue, Alex, and then Dr. Cook after can also add.
Sure. So in terms of our ED, I think initially, obviously, people were scared to come to the emergency room. And so they were waiting until the very last possible minute to come, which I think also has an effect on how severe their withdrawal is. And then in terms of, like I mentioned, our clinic practice, our volumes have been increased. Our approach for this patient in particular, and in most patients in this situation, is that we are dosing them with a 10 milligram per kilogram phenobarb load in the emergency room, observing them for about an hour or two, seeing what their vital signs are doing, see if their adrenergic heart rate, blood pressure, tremulousness is improving, and then using any adjuncts as needed. I know this case in particular, they use some clonidine, which we have been using clonidine patches. Some patients that if they're a little bit more uncontrolled, will be doing a Precedex drip. And then we don't typically do a prescription for a benzo, especially if the patient's going home. Just as highlighted in this case, the risk of patients drinking on top of that. And then just depending on how they do after the phenobarb load, obviously we're giving them high dose thiamine and folate. We'll determine whether or not the patient will come in for an observation stay, a full admission, or whether or not they're doing well enough to go home.
Yeah. And Alex and I work on the same service. So we see a lot of the same tox patients. I probably work a little bit more in the emergency department right now just because she's in fellowship. And just speaking from my shifts in the emergency department, a lot of complications from alcohol use disorder that I'm seeing more than I typically would prior to COVID. Alcoholic gastritis, pancreatitis, AKA, withdrawal, or any combination of the above. I think our kind of philosophy has been to hit them hard and early with phenobarbital, sometimes using, benzodiazepines just as a bridge because they're there in the Pyxis while we wait for the phenobarb to come up from the pharmacy. But the phenobarb is definitely our treatment of choice, and we use it early.
That's great. The protocol reminds me of one that I learned from Highland Hospital, Oakland. They published in a 1987 Annals of Emergency Medicine paper, 260 milligram load with subsequent dosing every, I believe, 30 to 60 minutes. I'd have to look at the specific intervals, and found that they're able to take most of the moderate withdrawal cases, which actually in review, the symptoms were fairly significant, including quite frequent seizures, and then safely discharge them from the ED. And this is at a county hospital where the inpatient units are basically full if they didn't have another medical condition. And it sounds like your model is very similar to that, although the doses that they were using in Highland aren't the same. Your load of 10 mg per kg is a higher dose. And I'm wondering how frequently you are able to stabilize patients versus that they need to come in for ongoing treatment.
Well,
Yeah.
Go ahead, Alex.
No, I was going to say, I think it just depends on how early in their course we're called. If we sometimes we'll even load them with phenobarb while they still have alcohol on board and they're not totally in forward withdrawal yet. And if we catch them early enough, I think we stabilize their alcohol withdrawal fairly well. And then, like Dr. Cook mentioned, they usually are coming into the hospital for some other reason, like abnormal electrolytes or pancreatitis. And then prior to COVID, we would err on the side of caution and keep them for a 24-hour ob so that we could link them to treatment. But I think it all just depends on the time course of when you're catching them in their alcohol withdrawal, how well the phenobarb stabilizes them.
Yeah, I agree with that. The ones that I've noticed that we seem to have the best luck with are the ones that we start when they still have alcohol on board. They may be showing signs of withdrawal, but they still have a significant of alcohol on board. And we know they're coming in because of that, because they're refusing to go back to drinking, and they just say, I'm going to go through withdrawal, you need to help me, or they have something else going on like pancreatitis or AKA that we need to admit them for. But not waiting for them to really show signs of florid withdrawal, just starting it early, knowing that they're going to go into withdrawal seems to give us the best result.
That's great. And I just have another question in particular because you're in Pennsylvania. From what I understand, the liquor stores are controlled by the state, and the liquor stores were closed, but the supermarkets were still able to sell wine and beer. And do you feel that the increase early on in particular was related to closure of the liquor stores, or were people just drinking more because of isolation? And what's your perspective on, the increasing presentations and severity that you're describing?
It was probably a combination of both of those factors, in conjunction with, I think, people having recurrences of use due to the social isolation and boredom and not having their typical day-to-day schedule. I mean, we've certainly seen all three of those scenarios. The liquor stores were closed, and people that typically could just, and a lot of people too, if they didn't have the ability to drive and they were in walking distance from a liquor store, they couldn't get there. And they also then couldn't get to a grocery store that sold a different type of alcohol. And then the social factors that go along with it as well.
That's great. I had a couple questions from the audience. First, yes, this is being recorded and the slides are available. And we do have some examples of the phenobarbital protocols that are available as well, that are included in the slides, but you can also send out if per request. Let me ask Dr. Swoboda in Illinois. First, what was the practice with the alcohol being available, and what is your experience with regards to alcohol withdrawal on your tox service?
Yeah, we in Illinois, we've had continuous access to alcohol, so they never really shut down the liquor stores or anything like that with the pandemic. But we still have continued to see increasing, I would definitely say, increasing severity of the withdrawal that we're seeing. I've been seeing more alcoholic ketoacidosis, so getting consults from my toxicology side of the service to rule out toxic alcohol for alcoholic ketoacidosis cases, in the past couple of months than I probably got in the year prior to that. So we're seeing a lot of increased severity. I think that whether it's some of our, say stable patients who I have in clinic who then suddenly relapse and escalate quickly, or other people at home alone isolated whose drinking also escalates quickly. I think the isolation is causing people to kind of reach this high level of drinking fairly quickly. So that's what we're seeing.
Thank you. Dr. Hurley, in California, what was the experience at the liquor stores? And I know that you've been heavily involved in ambulatory detox, but do you have any comments on this particular case, or just regarding the alcohol use and dependence during COVID?
Well, coronavirus, as the co-panelists have mentioned, has increased social isolation, and people are drinking more. And I also think people's access to alcohol has been pretty variable. One of the big reasons in LA County we needed to set up an ambulatory withdrawal protocol is that LA County has the most number of people experiencing homelessness in any jurisdiction in the United States. And we needed to rapidly find places for people to quarantine themselves, right? So we set up these emergency shelters. And while we were able to set up a harm reduction approach where we're able to facilitate access to alcohol at some of these emergency shelters, access to alcohol wasn't always available at all of these sites. So we needed a strategy to manage alcohol withdrawal, both for people experiencing homelessness, but also, in instances where people's usual and ordinary access to alcohol was disrupted. As with my colleagues, California, like Ohio, we have not seen mass liquor store closures. We have not, you're still able to purchase alcohol in many different areas. But it's challenging to use a benzodiazepine in outpatients that likely will take their benzodiazepines and drink on top. And so while the ASAM National Practice Guideline for alcohol withdrawal management does highlight that benzodiazepines are first line, they have a relatively healthy therapeutic window for safety, that we decided to go with high-dose gabapentin or carbamazepine as an agent for ambulatory withdrawal management, with a plan to quickly escalate somebody to inpatient services where they could go get benzodiazepine if they broke through. But the doses of gabapentin we were using were sort of quite high. We're looking like 1,200 TID for the first day or two, with the idea of getting all of the seizure prophylaxis benefits. Gabapentin does help people reduce their alcohol use, and also starting a medication for alcohol use disorder. So also starting a medication like naltrexone. And in this particular case, this patient has a mild transaminitis, but the AST, ALT in the 100 to 200 range just wouldn't preclude this patient from receiving naltrexone, which would also help treat the underlying alcohol use disorder that drove this patient to go into alcohol withdrawal to begin with. But in a case like this, I think we would be using ideally high-dose gabapentin earlier on so we don't get behind. That's one of the other things that happened in this case, is that this is somebody who went for several days with escalating alcohol withdrawal syndrome, who then presents to the hospital kind of, in the midst of their most severe moment of alcohol withdrawal in that time course. And so that's when you've got to be more aggressive around trying to catch up to the alcohol withdrawal. But if a patient like this was to be treated, if we were able to say start high-dose gabapentin or carbamazepine prior to the person really having that escalated alcohol withdrawal syndrome, it's possible we could have prevented a hospital admission. And if the patient broke through those things, which is certainly possible, they could always go to the hospital. The idea is they're not going to the hospital sneezing, right? They'd be going to the hospital with at least some alcohol withdrawal syndrome prophylaxis and treatment on board.
Yeah, those are great comments. In fact, we had a case last month regarding ambulatory detox, basically mirrored your protocol. I have a little bit different protocol, 600 QID with an extra dose at night, and clonidine adjunctively, and we'll use valproic acid instead of the carbamazepine. We had a comment from one of the audience, what about gabapentin clonidine in addition to valproic acid, which has been what I will use in the ambulatory detox. And I completely agree with all the panelists, starting ahead of the onset of the more severe symptoms makes an incredible difference. We're going to move ahead and describe this case in more detail. Patient is given 2 milligrams of chlorazepam IV, which is usually what happens in my experience, even when there's phenobarbital protocols available. The benzodiazepines are the quickest. 4 milligrams given 30 minutes later with minimal improvement. Thiamine, dextrose, along with electrolyte replacement, as Alex had mentioned, it's very critical to get the vitamins, the thiamine, and carbohydrates in. Despite the benzodiazepines, 2, then 4, and a second 4, 1 hour after the first, the patient remains tachycardic and hypertensive, and he's now intermittently sleeping. It's in the early morning. He presented late at night, but only briefly. When he wakes up, he's quite restless, and he wakes up really startling, becoming agitated when a nurse approaches or vital signs are taken. Phenobarbital is administered after the emergency department discusses with the hospitalist and the toxicology CL team, and a 10 milligram per kilogram IV load is given, after which he improves, but he is still somewhat restless. His heart rate remains at 100 to 110 beats per minute. We've already discussed any changes to your alcohol withdrawal protocol and approach during COVID, and I'm wondering, Dr. Magnuson, can you comment from the ICU perspective if you're seeing more patients that seem to have challenges stabilizing initially. What's your perspective in admitting the patients with alcohol withdrawal syndrome over the last couple of months?
Sure. Thanks, Tim. So, I don't have personal experience admitting anybody with just isolated alcohol withdrawal syndrome or any sort of complicated withdrawal syndrome. Obviously, it's in the setting of, usually a respiratory failure or, and there's been some reports of, fluid cardiac failure. And obviously, just the concurrent illnesses make the withdrawal syndrome much worse. So again, in our institution, because I think you've been pivotal in it, we tend to use a lot of phenobarbital up front. And the thing that's been different with the COVID patients, obviously, is generally we would be at the bedside reassessing quite often. And now with obviously staff safety and PPE utilization, the frequency of reevaluations were diminished. So maybe a little bit more heavy-handed up front, and maybe leading to a little bit more obtundation initially. But other than that, really hasn't seen much a difference, other than just these people are obviously incredibly sick, sort of from head to toe, which makes everything look a lot worse.
Right, thank you. The patients, they'd either try to self-detox and go 48 hours without sleep or fluoride withdrawal, or have been in a setting that is suboptimally treated withdrawal. Maybe the jail or incarceration has kept them in a medical ward, and it really gets out of hand. Have been some of the most complicated. And as Dr. Magnuson mentioned, often they come in not just in withdrawal, but delirious and have aspiration pneumonia, acute kidney injury, and rhabdo and ketoacidosis. So there's a lot going on. In this case, the hospice team calls for recommendations after the load, as he was still pretty symptomatic. Usually they quiet down quite nicely in their experience after the phenobarbital. And so additional recs are given for 130 milligrams IV every 2 hours for mild withdrawal, 260 IV every 2 hours for more moderate to severe withdrawal, along with 50 milligrams of quetiapine at night if there's delirium or insomnia, try and get his sleep-wake cycle back on. Additionally, clonidine is added every 6 hours to hold if his heart rate's under 80 with the 0.1 milligram patch per week that's been placed as he's admitted. And after 3 doses of phenobarb 260, the patient is sleeping, his heart rate's in the 70s, his blood pressure is 110/70. He wakes up with stimulation, but he falls right back asleep. And no further doses are required after that 3rd dose. Oral clonidine is not needed but the patch is continued. It's discontinued after that week. Quetiapine is utilized for hospital day 1 and 2, but not after. And I'm wondering about any additional comments to the adjunctive use, agent use, or other alcohol withdrawal regimens impacted from COVID. Dr. Hurley mentioned clonidine. If the patients hit the ICU, if they're in severe withdrawal, often dexmedetomidine, another sympatholytic, may be used adjunctively. We heard about valproic or carbamazepine adjunctively in the ambulatory setting as well. I'm wondering if there's any other comments from the panelists. Dr. Ramsey, do you have any thoughts maybe about connecting this patient from the hospital to ongoing treatment?
Sure. So I think particularly right now in the context of COVID-19, it would be super important for this patient's discharge plan to be linked with some type of provider in the community, depending on the setting that the patient was willing to do. And so perhaps like an FQHC partner, for instance. And ideally doing that linkage before the patient leaves the hospital, perhaps even having a telemedicine introductory visit so the patient could meet the provider or the team that might be taking care of them on the outpatient basis. It certainly might make him feel more comfortable about that transition from inpatient to outpatient.
Yeah, that's an excellent thought. In fact, with the emergency regulations during the pandemic, there were unique opportunities to provide telemedicine as well as bill for telemedicine. I don't know if it would have been billable while he's hospitalized, but certainly a supportive opportunity. And we'll talk a little bit about that during some of our later cases. Dr. Bashevitz, do you have any thoughts on this patient linking from the hospital to outpatient programs or in treatment in general?
Sorry, I think telemedicine is certainly a great idea, and the more we can introduce people to treatment while they're still in the hospital is, the better off we will be. The only caveat I would have is that this guy has very few supports, and he drinks a lot of alcohol, so he's got inpatient rehab written all over him too, and you might admit him to outpatient, but have a very low threshold for getting him into some sort of inpatient rehab facility if he's agreeable to it, and if such is available given his insurance. So that would be one of the concerns about this.
Tim, I just want to add one additional comment. It's Kelly again. So I totally agree with you that the patient likely would benefit from either a further inpatient rehab stay or linkage to an outpatient program. But again, it has to do with what is that patient willing to do at this moment in time. And the patient may or may not be, and depending on what state you live in, what's going on in your addiction treatment system right now with COVID-19. Even though they're not supposed to be halting admissions, are they? So it's just another thing to think about. And I think ideally, too, if this person were not willing to do any of those options, then you look at maybe there's a community-based organization or an outpatient, just a primary care program where that person could go and get support from, say, a peer.
Yeah, those are great comments. And it was a moving target, certainly in New York. The ability to link to inpatient from the hospital was very challenging early on. And more recently, it's been easier. And we've had variable success and willingness depending on patient motivation. I think one of the key limitations, too, has been the visitor policy has been really restricted. And we've often leveraged family support into helping a patient understand the benefits of going to a higher level of care potentially. And that's different over the phone or even with video compared to at the bedside working, together. We'll talk a little bit more about hospital visitation and limitations, but want to complete this case. The patient recovers remarkably well after the additional phenobarbital, despite remaining on a CEWA protocol. He's not scoring enough to receive additional doses. He's appreciative and recounts the history which was provided, corroborates initial info, and states he wants to avoid going back to that again. So what additional options are there to treat patients with alcohol use disorder after initial withdrawal management in a hospital setting? Some of this is already covered. I heard Dr. Hurley mention naltrexone, and in fact, that was started in this patient. His transaminases weren't high. We don't have the extended release naltrexone available as a shot from the hospital setting yet, but looking into that, and that was started as well as, in this case, an off-label medication, gabapentin, to continue for craving, which I will use in patients that do not have opioid or combined stimulant use disorders, otherwise would have considered looking at a camprosate. The patient's primary care physician was contacted and wasn't aware that alcohol had been much of an issue. Appreciates the context from the hospital, agrees with plans, referred to an outpatient CD treatment. The patient was resistant to going directly inpatient, and he will follow 1 week later with a telemedicine contact and no longer prescribe the lorazepam. The patient agrees to try the naltrexone and gabapentin, which is started at 600 TID in the hospital with the plan of going up to 900 TID. And the first dose of 25 milligram naltrexone is given and tolerated well, and he's discharged with 50 milligram a day to follow up at an area outpatient treatment program that is doing on-site extended release naltrexone injections during the pandemic. He's given info about internet AA meetings and local meetings, and also while in the hospital shown how to download a PDF of the AA book. While in the hospital on the last day, he expressed some interest in at least checking out AA. And wondering if there's any additional comments, maybe keep it brief. We've got two other cases.
Tim, it's Kelly. I'll keep it completely brief, but just two things. One is that this person's primary care provider wasn't aware of this person's alcohol use disorders. So I think it's again a reminder that patients are underscreened in the context of primary care for both alcohol and substance use disorder. And we know that brief intervention with alcohol is certainly efficacious in the primary care and actually in the ED setting as well for mild to moderate alcohol use disorder. And that the USPSTF just recently recommended screening all adults 18 and above for substance use disorder. The second comment I would make is just that while this patient was amenable to AA, not all patients would be amenable to 12-step meetings, to also include other resources such as smart recovery for patients.
That's great. I listened in on the addiction medicine fellowship graduation, and the increasing alcohol use was really stressed, and the use of liver function tests and other biomarkers to determine, if alcohol consumption may be excessive in primary care was really emphasized as well. So your points are well taken. I do have some examples of phenobarbital protocols for alcohol withdrawal syndrome treatment in the hospital. And again, these are just brief kind of examples with some references that can go into more detail regarding alcohol withdrawal. And I would encourage individuals to look at the ASAM guidelines for alcohol withdrawal, which include recommendations for treatment at all levels of care. We're going to move into case 2, which involves one comment. Yes.
Yes. Henry Swoboda here. I just want to say, in the age of COVID with our COVID patients, we've been pursuing strategies to decrease the number of in-person assessments our nurses are having to do with CEWA and all that. And even though we think symptom-triggered treatment is kind of standard of care, I think that upfront phenobarbital loading we've been pushing more and more. So either the 10 milligrams, or if they've already got a bunch of benzos, we might go with 5 or 260 at a time, depending, to get them loaded up front. But then we've also instituted some standing dose protocols with either gabapentin at those standing doses that we then continue in the outpatient setting. So those are for our moderate or mild risk patients, or we've based some ongoing phenobarbital just scheduled dosing for patients with severe alcohol withdrawal to help us kind of cut down on our frequency of assessments, kind of based off of that. There's a Tidwell article from 2018 that we've done that with to help with our COVID patients specifically.
Yeah, that's great. And I believe that's one of the references also included and embedded. So thank you, Henry. Right, case 2 involves an interesting question that I had received from one of the ICU fellows in the hallways as I was rounding a couple weeks ago. He asked if there's any utility in using buprenorphine and some other techniques for some of the severe critically ill COVID-19 patients that often require prolonged sedation and analgesia. So just one example is the 40-year-old male who had been hospitalized with COVID-19, pulmonary sequela complications, ended up requiring intubation due to hypoxia and respiratory failure, has been in the ICU for 2 weeks, requiring very high doses of sedatives and opioids in order to control symptoms and minimize the need to interact with patient. Less sedation, wean, apparently, and Dr. Magnuson can comment in a moment about their protocol and involvement. The medication this patient was receiving was midazolam at high doses per hour, fentanyl, which was later switched to hydromorphone. I believe there's some shortages of specific opioids during the COVID pandemic. And 14 days in, any weans are associated with agitation. He's not tolerating pressure support. So Dr. Magnuson, can you comment on how COVID-19 has changed sedation and analgesia protocols in the ICU, and in particular, any other pearls or comments?
Sure. So I'll try to keep it brief just to get us back on time. But yeah, obviously COVID-19 changed everything, and that included our pain and sedation practices. Obviously standard of care for the past several years, if not decades, has really been light sedation in the ICU. The old mantra of a critically ill patient with respiratory failure that has to, quote unquote, wake up and breathe every day. So doing a spontaneous awakening trial in addition to a spontaneous breathing trial, if the patient's illness allowed the breathing trial, was something that was obviously pivotal, more than sort of 10 years ago, in order to reduce our overall sedation and obviously improved outcomes from, ventilator-free days, but also even mortality. So we went back to old practices for deep sedation, and that was probably for several different reasons. Number one, the lung injury of COVID-19 was sort of bread and butter ARDS, with a stiff lung. But there were also other phenotypes of sort of this floppy ARDS where the compliance of the lung wasn't all that impacted. So people were taking very large breaths on the ventilator. And obviously one of the hallmarks of respiratory failure care is low tidal volume ventilation. So what we would see is escalating doses of pain and sedation medications in order to have them comply with these low tidal volumes set on the ventilator. We also did use quite a lot of prone positioning, and people just generally do not tolerate that when they're sick and uncomfortable. So again, escalating doses of pain and sedation there. There was also a lot of talk about the neurotropism of the coronavirus and how it directly impacted the respiratory center of the brain. So even though these people subjectively may not have felt out of breath, they objectively looked very out of breath and were significantly tachypnic and hypoxemic. So that again led to people's comfort level of just deeper sedation there. And then again, what we already talked about is sort of staff safety and PPE utilization. So our med pumps were actually run from the patient outside the room using lots of tubing. So the nurses didn't have to, go in the room and, don PPE all the time. So I think that also led, like you said in the case here, to less, interaction and less sedation weans. So definitely saw a lot of medication overuse that did definitely lead to iatrogenic dependence and ultimately, and unfortunately, some substance withdrawal syndromes in the ICU.
And how typically did you handle that? What were your protocols for the complicated weans? Is there a couple different algorithms that you use? Just run us through some of those.
Yep. So the pharmacist actually sort of, wanted to use phenobarbital as sort of, the medication of choice as far as weaning some of the continuous anxiolytics. So we would give phenobarbital generally 4 times a day and then sort of taper daily for, I believe, 2 to 3 days. I like to use higher doses of gabapentin, like one of the panelists had mentioned earlier. That was never a formal protocol, but something that whenever I was on the highly infectious disease unit, I would use that. We used dexmedetomidine a lot longer, not necessarily more frequently, because that is a great drug that we use often at the University of Rochester, but we definitely used it for longer and longer periods of time. Again, higher doses of antipsychotics. If the ECG, QTC was allowing that. And then we just saw very slow tapers, whether it was IV reducing the continuous infusion rate, by 10 to 20% daily, or if it was starting a transition to oral medications in place of the continuous IVs.
That's great. In the last several years, our service has been involved in more of the ICU patients that have substance use disorders, dependent on sedatives and opioids when they've been involved, whether it's multi-trauma and end up in the trauma ICU, or for whatever reason, initially an overdose and are hospitalized, supported, and with the complicated weans when they're dependent, often getting the patient onto buprenorphine and using phenobarbital, like you'd mentioned, an adjunct of dexmedetomidine. The buprenorphine in particular, if they have opioid use disorder and opioid dependence, I think is very useful. And we've used some kind of novel ways of getting patients on microinduction, which entails starting very small amounts per hour. Very small amounts every 6 hours for the first day, increasing slowly while the full agonist is in place over a course of 4 to 5 days, introducing the buprenorphine and then taking the full agonist off. There's a number of different ways to do that, but it seems to help with some of the complicated weans when patients are really not tolerating sedation titration. Dr. Swoboda, do you have any comments? I know you've been involved in some of the ICU care, and we've discussed this on previous case conference.
Yeah, absolutely. We've been getting a lot of consults for these sorts of patients. We have only occasionally used phenobarbital because in our experience, the kind of dependence that seems the hardest to shake has been the opioids. We've managed to get people off of propofol and benzos without too much trouble for the most part. If we need to, we'll do that phenobarbital load. But one thing we've done is set up a protocolized use of methadone, kind of based off of there's a randomized control trial in adults. It's used fairly frequently in kids when this iatrogenic dependence happens. There's one randomized control trial, Wanzuita et al. Published, where they kind of start 10 milligrams Q6 of methadone and rapidly wean off the fentanyl or other drips from there. And so we did a kind of a very similar approach where we will decrease the drip by at least 25% every day once they start getting that 40 milligrams of methadone split up daily. And then likewise, we'll use the buprenorphine, usually for the patients who have managed to get off their opioids, but who are already in withdrawal. But we have IV buprenorphine, which has been really helpful for us. So as soon as 4 hours after they've had their drip turned off or after they got their last opioid, we'll start them on standing 0.3 to 0.6 milligrams of IV buprenorphine every 4 hours as a way of loading them up. And then we switch to PRN afterwards, and it'll kind of self-taper that way.
Yeah, that's great. We have used that in our experience, but we have the Butrans, not the Belbuca formulation, which is the sub-milligram doses that we've used Buckley while they've been intubated for the first couple of days. Dr. Amaduchi or Dr. Cook, is your toxicology service involved in the ICU sedation support weans with patients that are dependent or in withdrawal? Do you have any additional comments?
No, we haven't really been consulted on too many weaning issues. We do see it outside of COVID with patients with substance use disorder, but we haven't really had that many issues with patients requiring increased sedation for COVID-related reasons.
Thank you. I think we've covered most of these questions. There's different protocols that we've discussed. For the patient, we discussed incremental loading using phenobarb while reducing the midazolam. 260 milligrams IV for 20% reduction in midazolam was done along with adjunctive dexmedetomidine. And we had talked in the hallway at least about the microinduction with buprenorphine if the fentanyl wean remained challenging. And the team used IV phenobarb, had to switch to hydromorphone. There were shortages of fentanyl infusions, but decided not to use the buprenorphine. The station wean was complicated, prolonged. There's some aspiration, pneumonia as well, delirium. Discussion on protocols for phenobarbital, buprenorphine, and other regimens were initiated with some of the ICU teams after this case. And in my experience, like we discussed, we've had a lot of success using buprenorphine when there's primarily opioid use disorder, opioid dependence, focusing on that, taking that out of the picture first, which is a little bit different than the COVID patients with iatrogenic dependence. We're going to move along to case 3. We've got about 18 minutes left, and this is a case with a lot of discussion. This involves a 29-year-old female with opioid and stimulant use disorder. She has IV drug use associated severe aortic valve endocarditis with perforation and severe aortic regurgitation. She's hospitalized during COVID-19. She's not complying with treatment regimens that are critical to success with valve replacement. She's refusing the heparin on occasion. She doesn't want an IV. If it's been blown, won't get another blood culture. Finally has a PIC placed, and that's all she'll allow to have access. Here's some stigmata of aortic valve endocarditis, some of the emboli to her feet and to digits. And this is painful for her. She has a history of IV heroin and cocaine abuse for about 10 years, and she'd been directly admitted from an outside hospital with altered mental status and fever. Initially, she was greatly impaired, lethargic, falling asleep in mid-conversation when asked questions. She's unable to obtain significant history from the patient initially. The outside hospital records indicate that she came down from the current area where she lives, which is in the area of the tertiary care hospital where she's currently being treated. She moved to the away to stay with a friend and had been there for about 4 days. She'd been weak, tired, and having diarrhea during that time frame. In the emergency department, her temperature is 38.3, heart rate is 110. She's confused and intermittently pulling at IV telemetry leads and trying to get out of bed. Reports of heavy cocaine use, daily heroin, fentanyl, but last for the friend. She injects it into her chest as an abscess wound that has been intermittently treated with chronic changes in her right chest wall. Last opiate use was fentanyl before going to the friends. She gotten some IV hydromorphine in the ED, both at the outset hospital and at the current ED. 4 years ago was on Suboxones, but I injected them, don't want it. At one point during the history, she's able to stay. She attributes her chest wound to injecting buprenorphine and buprenorphine naloxone that apparently it started initially. It's been a chronic problem since then. And the Tox Addiction Services consulted to help with dependence and stabilization as she's admitted for IV antibiotics and assessment for valve replacement. She obviously had, initially there was concern for infective endocarditis, which was confirmed with a TGE, and which demonstrated severe aortic regurgitation as well as a perforation. So my question is, what are the options for this patient to help stabilize with initially what appears to be opiate withdrawal and potentially other dependence and craving? Types of supportive medications and other adjunctive supports might you offer to her? Let me start with Dr. Hurley. What would your approach for this patient be?
Sorry, I didn't get myself off mute fast enough. So, it's challenging with a history of somebody that did not do well on buprenorphine. Usually we think about escalating to methadone replacement, or I shouldn't say the word replacement, opiate agonist pharmacotherapy. I also think that so that how I'd initiate stabilizing her opiate withdrawal. In terms of other support or directive med, typically if the person is able to tolerate a reasonable methadone dose, you titrate to effect. You don't tend to need a lot of other things such as clonidine or Bentyl or Imodium or other types of comfort medications.
Yeah, that's great. Thank you. Dr. Bishevitz, you've been involved in linking a lot of the patients from the hospital. I'm wondering, would you have any particular recommendations early on for this patient? And she is interested in methadone, but what are your thoughts?
Well, this is a great case to actually start on methadone in the hospital and then transition her seamlessly to an outpatient opiate replacement therapy program, which I think we may have tried in this case, but it doesn't always work out. We've piloted in Rochester starting people on methadone who are in an inpatient rehab part of the ATC system and using Zoom intakes from our outpatient program. And that has worked out very well and seems to help people stay in treatment for the next, before they get to the step in treatment. And hopefully it might help her. Often methadone has just a wonderful stabilizing effect that allows you to have something to work with in terms of a patient who is more receptive to thoughts about addiction recovery and so forth.
Yeah, that's great. And we're in the process of trying to determine whether we can do the same thing, be eligible in the hospital to have that first eval before linking them to the strong recovery or opiate treatment program, so we can titrate the dose up beyond what would be required, the ceiling for that patient to start at the opiate treatment program. So to go above 40 milligrams, for example, and have that initial eval. Dr. Cook or Dr. Amaducci, I'm wondering if this patient's in your ED, you are determining she has opioid use disorder, complications related to that. What are your protocols for opioid withdrawal in the ED?
Well, it kind of depends on what we're planning on starting them on, I guess. If it's somebody who is interested in Suboxone and they're not in bad enough withdrawal yet, their COW score is not significantly elevated, we have a panel of medications, NSAIDs, Seroquel, clonidine, gabapentin, melatonin, all included on that. And we basically just click them all off for PRN use to allow the patient to, withdraw to the degree that we can eventually start them on Suboxone. That's not this lady. She is basically saying she's not interested in that and kind of more interested in full agonist therapy, which I think makes those of us who are in addiction medicine trained a little bit more apprehensive. But if the goal is to keep this woman in the hospital, which it is, because she's going to be there for quite some time, right, receiving probably PICC-line antibiotics for many weeks, you have to do what it takes. And we will start these people that are, a hard no to Suboxone. We'll get them started on, a similar dose of methadone to what you're eventually going to describe here.
Tim, it's Kelly. Do you mind if I just interject something?
Sure, go ahead.
I was just going to say, too, it is really important to tease out what the no is about. Because sometimes I've had patients present who say, no, they don't want it. They don't think it works. But then when we break it down, what were the circumstances when she injected it? Why was she injecting it? Did she have other opioids on board when she injected it? So there may be reasons that have to do with that individual situation and not with how globally she might do on buprenorphine. So I think, if the patient clearly says no, that's no, but I think it's important to always explore the no.
Yeah, this is right. I was going to say the same thing. The context for how buprenorphine is used is almost as important as the molecule itself. Thanks for tolerating the interruption.
Yeah, no, I agree. I've heard of allergies that were precipitated withdrawal, or in this case, as we later determined, she felt that it was just a trigger for injection, and she also associated this chest wound with it. And it also was a trigger when she had the individual films to use more cocaine. So there was concern, which was interesting. We can talk a little bit more about that as the case evolves. So the patient had started on methadone, 10 milligrams, 3 times a day. It's split dosing for the analgesic effect, which is of shorter duration than keeping the patient out of withdrawal. After an initial dose of 20 milligrams times 1, she had a lot of improvement. Mood stabilized, symptoms stabilized. She still required some full agonist on top. Topiramate, 50 milligrams twice a day, started for cocaine craving. It's an off-label use of that medication, but typically what we do, she's admitted for IV antibiotics and evaluation for valve replacement. And again, as I mentioned initially, this is complicated by refusal, heparin monitoring, other treatments. And she really struggled. The policy of the hospital was no visitors, except in extremely rare circumstances. First admission was very early in the COVID epidemic. And so my question is, what resources do you have available for patients with substance use disorders and addiction if hospitalized during COVID-19? I mean, at best, it's a challenging population to keep in the hospital, but COVID-19 particularly impacted them without the ability to go outside and smoke a cigarette, or to have family or friends come in and visit and drop things off. There were some mechanisms for that, but not to directly visit the patient. So I'm wondering, what were your resources for patients in the hospital? Dr. Bashevitz, maybe you can comment on what you saw utilized or had recommended.
We saw a lot of utilization of peers, where the peers would use technology to, or just phone, to communicate with the patient and point out resources to them, especially if they had the technology, iPads or something, then the patients would be informed about the AA meetings that are online, and NA meetings, and other local resources that are interesting online. We have some exercise stuff available online, and all sorts of stuff. In fact, some of my patients told me that they particularly enjoyed the AA during times of COVID, because they were able to attend meetings across the country or in London or wherever. Is an interesting thing about that. Yep. The other thing, if chaplains are still able to talk to people, there have been some of that type of thing, and certainly family resources as well over the phone, but that's about it.
Yeah, this was complicated because she did not have a phone initially, and while there was an iPad available on the unit, it was set to only allow FaceTime calls or a Zoom meeting, which limited the ability to access other things online. We did arrange some peers, which she had contact through prior that went out in the community, and she did get some calls to and from her room. There was going to be a comment. Was that Dr. Hurley or who was going to?
Oh, I was going to say just about the context for how we connect people to treatment and how we deliver treatment on transition. But I think I made that point. I don't need to belabor it.
Okay. The patient has a long discussion with the Tox Addiction CL, and she's made aware of the availability of the iPad she can use in FaceTime. Didn't have the phone. She's familiar with the local peer. It's ahead of a program called Hope Dealers, Be the Change, and agrees to call with the peer. Brought some books in. She was really resistant, just angry, and needed, I think, the direct communication. It struck me that really spending time at the bedside with her was really probably the most therapeutic thing. And that when, someone wasn't spending more of the time, then it seemed to be more of the refusal cares. Brought in a book. She liked poetry, so The New Path of the Waterfall, which is a really good book by Raymond Carver, Homemade Math. And she starts to engage more, but still has intermittent refusal cares, and CT surgery ultimately gives an ultimatum of she needs compliance for 3 days or no surgery. And, she literally had 3 days of compliance needed, which was not going in the right direction. So, Dr. Hurley, you've been involved in motivational interviewing, presenting to ASAM and others, and I'm wondering if there's any particular techniques you would utilize to really work with this patient beyond what we've already said.
I'd start by evoking their readiness. I mean, you have to start with engagement, right? The patient is going to talk to you, but if you're engaged, and then you can find an area of focus. If the patient can agree that the substance use that's driving dysfunction is an area that they might be worth talking about, then to evoke her readiness, her intentions, her goals is oftentimes the best place to start, because it's pretty common for, and I'm not saying no persons to my hospital's colleagues, to say you need to go to AA, or you need to stop using, or you need to whatever it is, right? And if we stop, attended to, if we're even engaged with the patient's even ready to have a conversation with us and agreeing to put substance use on the table of things to talk about, then evoking what she might be ready for is the first step. Because you'll find that patients are oftentimes your recommended, what you would recommend, but you have to sort of accompany them there. If you sort of say, well, this is what you need to do, patients will very oftentimes, they will show unreadiness and sustain talk and discord and say, no, like I'm not going to do that just because you're telling me you have to. Bring them along. Oftentimes you can be all the more effective.
Right. And this case in particular literally evoked some sensations of panic because she was really having severe effects from valve replacement, and it at one point felt like you need to imminently comply, and trying to engage and work with the patient at that level when we've got a timeline and stress. It was very, very complicated.
Very stressful.
Team meetings
very stressful.
Occurred. Discussed medication use. She was doing okay with the methadone. There was no opioid withdrawal, and she had ample pain control. She'd agreed to certain treatments, only to be followed by not doing so. She developed anasarca, edema, wasn't wearing TED hoses, intermittent refusal diuretics. Her bacteremia cleared on IV antibiotics, and after 2 weeks in, she signed out of the hospital because they kind of abruptly said, my father died of the same thing I have. Apparently, we learned her father had an MI, but he had endocarditis as well. Whether it was acutely or chronically, it's not clear. About 2 weeks later, she represents. She's taken oral antibiotics. and reports only intermittently using fentanyl, no cocaine, is admitted to complete day 38 of 42 by the antibiotics. Same strategies, split the methadone dose. She declined the link to the opiate treatment program at the last DC, peers and books. And again, due to her compliance, she did not receive the valve replacement, was medically managed with info and linked to ongoing treatment. And her home environment is a bit challenging. Her significant other drinks heavily, but is not using heroin and cocaine. And then on follow-up was not answering peer calls. Her AMA discharge into the second hospitalization included a discharge with metoprolol, torsemide, topiramate, and again, declined the referral to the OPP. And she was set up with a primary care appointment as well as some peer follow-up, and the case is ongoing. We've discussed how COVID has dramatically altered hospital visitation policy and, cares, I think, in making sure that nicotine replacements is available and, other substance use is addressed and whatever resources you have, leveraging appropriate community resources. I'm going to jump ahead. Some community resources impacted by COVID-19 that we've had in our area. I mentioned the Hope Dealers Be the Change, which is a community nonprofit volunteer group that meets on a Sunday in Rochester and has many peers working. Has picked up 127,987 needles to date. Over 10,000 lunches provided. 168 persons who use drugs helped in the recovery from street contact. A lot of naloxone kits distributed, but their on-site presence was impacted by COVID, so they could no longer set up a tent during COVID, but they did continue to man phones for volunteers to support people as peer counselors and just others. And Recovery Fitness, another community examples of fitness related recovery program that people would go to for classes, their calendar events, 3 or 4 things a day, from meetings to fitness to outings to hikes in Adirondacks, all sorts of things. It wasn't completely taken off the table. This is their virtual calendar of events during the COVID pandemic, but the in-person stuff was really taken off the table and unfortunately limited, which that contact is really important. I want to end with this poem from Raymond Carver, Gravy. It's one of the ones I shared with the patient. Gravy, no other word will do, for that's where it was. Gravy, these past 10 years alive, sober, working, loving, and being loved by a good woman. 11 years ago, he was told he had 6 months to live. At the rate he was going nowhere but down, so he changed his ways somehow. He quit drinking. The rest, after all that, it was all gravy, every minute of it. Up into, including when he was told about, well, some things that were breaking down and building up inside his head. Don't weep for me, he said to his friends. I'm a lucky man. 10 years longer than I or anyone expected. Pure gravy. Don't forget it. I want to thank everybody for joining. We're right at 2:00. Please join us for this next third Friday webinar in July. If attendees are interested in being a panelist, please send me an email. Both ACMT and ASAM have ongoing webinar events and resources related to COVID-19, so I would direct you to the web pages. And I want to thank our panelists for joining me today and Dr. Bishevitz in this case discussion. This is recorded and will be available on both ACMT and ASAM websites as PDFs. And there are some resources embedded, but if anyone has additional questions or protocol requests, please email me or the other panelists, and we can follow up as well. Thank you, and everyone have a great weekend.